From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, and welcome to this JAMA Author Interviews podcast. I'm Dr. Wolfgang Winkelmeyer, an associate editor at JAMA, and I look forward to being your host today. We will be discussing the topic of hypertension and kidney function after living kidney donation today. And joining me on this podcast are Dr. Amit Garg, who is a professor of medicine at Western University in London, Ontario, who is the corresponding author of an important study published in JAMA. And we have Dr. Elizabeth Lawrence, associate professor of medicine at Baylor College of Medicine in Houston, Texas, who is a transplant nephrology specialist and the lead author of an accompanying editorial that comes with Dr. Garg's very interesting study. So welcome, Dr. Garg and Dr. Lawrence, and thanks for being here with us today.
Thank you.
Thanks.
So, Dr. Garg, what was the evidence gap and what drove you to design and to launch this study at the time?
Thank you. So this study has been in the works for over 20 years. My practice is advanced CKD, so I care for people with advanced chronic kidney disease, including those on dialysis. And I also had the privilege of serving as the director of our Living Kidney Donor Program, where I've evaluated, I think, over 1,000 donor candidates over the last 20 years. And when we evaluate people who are undergoing the donor process, we want to be sure we have good information on what's likely to happen to them after donation. Living kidney donation is a wonderful treatment option for people with advanced kidney disease. Receiving a transplant results in better survival and quality of life and reduced healthcare costs compared to dialysis. And if you could get a deceased and living kidney donor transplant on the same time, a living kidney donor transplant results in median graft survival, let's say 15 to 18 years versus 12 to 15 years with a deceased. And at least in my jurisdiction, it's almost 4 years to wait for your first offer for a deceased donor kidney. So we really are trying to promote living kidney donation as the best treatment option for our patients. But we also have this profound responsibility to make sure that we're caring for that living donor and making sure they're not subject to untoward consequences from their donation process. And this is even more important in donation because many donors are doing it with emotive decision making. My wife needs a kidney. I'm, of course, going to give her a kidney. So in that context, it's really quite important that we understand what the outcomes are. This has been an area of study. When I first started in the field 20 years ago, we knew less. We know a bit more now, but still, there's some uncertainty in the estimates of what happens to living kidney donors. And this particular study was focused on that first decade after donation. And the reason why it's been challenging is that our best estimates of treatment effects come from large multi-center randomized controlled trials, but you can never randomly allocate people to kidney donation. So you're always left with observational studies where we're comparing a group of people who donate kidneys to a group of people who don't donate. But the consideration has been whether this is a true apples to apples comparison or is it an apples to orange comparison, because you have to go through many tests and have quite good health to become a kidney donor. We know that kidney donors often have also genetic predisposition to kidney disease. Many of them are related to the person with kidney failure. And in follow-up, often kidney donors get more testing and routine care than the average non-donor. And so those considerations have made estimates in the literature uncertain. And recent guidelines have called for more information in this space. And so that's what we were trying to address with this study.
Fantastic. So can you briefly summarize what exactly you did and what were the main findings?
So we put together the study concept where we would enroll donors and also enroll non-donors before the donation process, have some set of testing that was done in the non-donors to try to make both groups as comparable as possible. You're never going to be perfect because the donors go through much more testing, but some simple tests of blood pressure, kidney function, that they were similar. And we ran this study in 17 centers, 12 in Canada and 5 in Australia. We enrolled a little over 900 living kidney donors and almost 400 non-donors. The median follow-up was around 7 years, and some were followed as much as 15 years. As a part of that process, we did very careful standardized blood pressure measurements. To be practical, we gave people home blood pressure monitors, which they took several readings, I think on average 16 or 17 readings before the donation process. And then they did that annually thereafter. So we had over 100,000 blood pressure readings in the course of the study amongst all the participants. And as well, we did measures of kidney function, such as serum creatinine, because that's practical to do, and random urine albumin-creatinine ratio for assessments of proteinuria, and also psychosocial surveys done before donation and in the follow-up period. Generally, it's at 3 months and then annually thereafter.
What did you find? What was the result of this study?
In the literature, some studies suggest that donation does increase risk of hypertension, and other studies suggest that's not the case. And as you know, there is a strong connection between blood pressure and the kidneys. In this study, we really try to be careful in our analytic approach that the donors and the non-donors were as similar as possible, including on a genetic predisposition to kidney disease and high blood pressure. And so we used the statistical weighting technique in the paper. And after we performed the analysis, we demonstrated that actually the blood pressure was very comparable in both donors and non-donors. And we saw no difference between the two groups. As we age, all of our blood pressure goes up a bit, but we didn't notice any between group difference in the risk of hypertension or in their blood pressure readings. The next thing we looked at is kidney function, the estimated glomerular filtration rate. And after you donate a kidney, you don't lose 50% of your GFR, you lose 25 to 40%. And in this study, particularly, the average drop was around 32%. And after that decrement from donation, we didn't see, at least during this time period, that the average GFR was further declining at a greater rate in donors. If anything, it went up a bit compared to the non-donors where it declined. In terms of the psychosocial functions, we often tell donors, and I tell donors, that while it's variable, most people after the surgical nephrectomy, typically done laparoscopically, they're home in a few days, and they should be feeling quite good at 4 to 6 weeks and fully recovered. But we actually found at 3-month mark, still there was a meaningful difference between the two groups in the physical measure of health. And so that has actually altered my own practice in telling donors that it could be a bit longer than what we were telling before in terms of the recovery period. But by 1 year, certainly, they were very similar to the non-donors.
These are really quite encouraging findings, I would say. And I also want to comment and dangle that out for our listeners today, that there's a wealth of information that comes in the study, much of it actually in the appendix. So Dr. Lawrence, what did you think when you read the study, when we asked you to editorialize on this? Did you find any specific nuggets in there?
Thanks for including me. I really enjoyed this study and was very impressed by it, and want to congratulate you, Dr. Garg, and your colleagues for doing this important work. Clearly, one of the main strengths of this study is the study design. You know, a lot of the prior studies that have tried to assess risk after kidney donation have been retrospective, maybe missed some confounders. This study was prospective. They went to great lengths to avoid loss to follow-up. In a study like this, to follow patients for a median of 7 years is no small feat, and they ended up with more than 90% of the cohort showing up for their final study exit visit. So I think I was just struck by the incredible amount of work and diligence that went into this study and how it's really a benefit to the living donor community. The second, like Dr. Garg already mentioned, was the control group. It's kind of been the bane of the prior literature, is making sure that the control group of non-donors is as similar as possible in terms of baseline health as the donors. Because this was a prospective study, they recruited the non-donors from the same centers as the donors during the same time period, subjected them to the same eligibility criteria. And so that really struck me as an important takeaway from this study. And then another interesting facet was the blood pressure measurement during follow-up. They sent everybody home, approximately 1,300 participants, with a home blood pressure machine, an appropriately sized blood pressure cuff. They taught them how to use the machine, and they had them measure their blood pressure at least every year for, a median of 7 years. And interestingly, I saw that half of the donors who developed hypertension during follow-up were diagnosed because of their own home blood pressure readings that they measured themselves and not by a healthcare provider. And I think this is an interesting finding because it highlights how sometimes the clinical follow-up of blood pressure in patients who have donated a kidney by healthcare providers can be inadequate, and that self-monitoring is very important. And then lastly, I just want to note that the study findings apply to the group of patients mainly in the study and may not apply. The study cohort was predominantly white individuals with access to universal health care. And so I just want to caution, they were not medically complex donors. And so in this age where prospective donor candidates have more and more comorbidities such as kidney stones and diabetes and pre-existing hypertension, these study findings may not apply to prospective candidates of other racial backgrounds or less access to healthcare or more baseline comorbidities.
Thank you, Dr. Lawrence. Very interesting. Dr. Garg, what's the clinical impact of this work?
Well, there are a few things. One is it was a bit uncertain whether donation increases the risk of hypertension. And we found here, at least in the first decade, that wasn't the case. We didn't find that there was a higher risk attributable to the donation process. The next thing is that in terms of the GFR, 40% of the donors did have at least one measurement of GFR between 30 and 60. None had a value less than 30. Many of us do this in our clinics, but really cautioning that if you do a lab test, it might say you have chronic kidney disease, and that can be quite worrisome because often they know someone who has kidney failure and they know the seriousness of that condition. And so further emphasizing the importance of counseling, that several donors involved will get into that 30 to 60 range, and that it might have a different prognostic significance, but don't be alarmed when you see this in the lab tests, I think is useful to say. And it's mentioned before, many of us counseled, although it varies, we say generally you're back to full fitness in 4 to 6 weeks. And I think this study shows that that's actually not exactly true. Still, many people 3 months out are still having decrements in their physical function. And so we should counsel that they perhaps need a little more time to recover from the nephrectomy.
Well, thank you. I would like to thank my guests, Dr. Amit Garg and Dr. Elizabeth Lawrence, for joining me today. A link to both the article and the accompanying editorial are available on the podcast show notes. This episode was produced by Shelley Steffens at JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks so much for listening.